I'd like to introduce Professor Claire Roger. Claire is a dear friend of mine and a wonderful collaborator that we've been fortunate enough to work with for many years. Professor Roger is the director of the intensive care unit at the Nimes University Hospital, and also has an academic affiliation at the University of Montpellier and has held that since 2011. We were very fortunate enough to host Claire in Brisbane for a year back in about 2016, 2017. And through that, we've been very fortunate enough to enjoy many collaborative projects since. And Claire's expertise and leadership, particularly in the area of dose optimization and renal replacement therapy, is very well known internationally. And so we're very grateful that she is able to join us for today's webinar. And so I would like to invite Claire to begin her presentation. Claire, would you like to share your slides?
Yeah, so good afternoon, everyone. I may need to have access to share my screen. Okay, it's okay. Can you confirm that you can see my slides?
Yes, thank you,
Yeah.
Claire.
Okay, so thank you very much for these kind invitations to give this talk on antimicrobial drug dosing in critically ill patients receiving renal replacement therapy. It's a really great pleasure to be part of this webinar, and here are my disclosure for this talk. So what we do know for years is that sepsis and multi-organ dysfunction related to sepsis will significantly impact antimicrobial pharmacokinetics. And for some patients, the renal dysfunctions will require organ support, leading to quite unpredictable antibiotic plasma concentration and exposure over underexposure. And probably one of the first studies showing this risk of underexposure for our patients is the EWA study that was conducted almost 10 years ago by a team in France, comparing two different intensities of renal replacement therapy, 35 milliliter per kilogram per hour versus 70 milliliter per kilogram per hour. And they found no survival difference in this study. But what they also observed was that the two groups were underdosed, and particularly higher clearances in the high intensity group, showing that we do need to adjust drug dosing for these patients. And this inappropriate antimicrobial drug dosing can also increase the risk of clinical failure, as observed in this study in particular with difficult to treat pathogens. We can see here that renal replacement therapy was a risk factor for clinical failure in patients with carbapenem resistance and antibacterial infections. But at the same time, we have an increasing literature in critically ill patients showing that we may observe toxicity, and in particular with beta-lactam, neurotoxicity reporting is increasing. And there's quite challenging drug like cefepime, and again, we can see that inappropriate dose optimization in these patients can expose this patient to an increased risk of neurotoxicity. So picking up the right dose for this patient is not that easy. And we have quite interesting data in the literature coming from the SMART study that was a large cohort conducted by Professor Roberts. And what we can see from this study is that first, if you do compare the different renal replacement modalities, we can see that the impact on beta-lactam may differ from a drug to another, and we can observe that for meropenem, here there's not a wide variability between renal replacement modalities, whereas for vancomycin, we have a significant difference between these modalities. But I think that the main message is quite well represented with piperacillin. We can see that we have a very wide inter-individual variability, with concentrations varying between 40 and 170 in this cohort. This may explain, this wide inter-individual variability may explain that it's very complicated for physicians to choose the appropriate dosing. And when we look at the survey on this topic, we have data from France and from US, and we can see that giving a clinical scenario to physicians and asking which dosing regimen would you use in these situations, we have also a wide variability in the answers, and a wide variability in the way to prescribe antimicrobial drug dosing for these patients. And these dosing complexities mainly relies on different factors that will affect antimicrobial PK. There's, of course, characteristics of the patients, the weight, the renal residual functions, the volume of distributions, but that's also characteristic based on the physicochemical properties of the drug you use, and also the renal replacement therapy modality or setting you apply to your patient. But there's still, it's a very complex situations, but there's still some general rules to apply for our patients. And the first one is that probably in terms of antimicrobial drug dosing, continuous techniques are easier to adjust drug dosing, because they induce quite more physiological elimination of the antibiotics compared to intermittent hemodialysis. And it's what you can observe on these concentration time profiles here. During the intermittent hemodialysis, you can see a wide variability in clearances across the session, and leading to a quite high variability in the concentrations observed in these patients. And it's definitely more difficult to adapt. Whereas for continuous renal replacement therapy, and in particular, if you use regional anticoagulations, the dialysis dose delivered to your patients is more stable and with a longer filter lifetime. So it may be easier to provide appropriate drug dosing in these patients, especially if when you use continuous renal replacement therapy, you use continuous infusions of beta-lactam. And we have data showing that when you compare two different modes of administration of beta-lactam, here, for example, for piperacillin, comparing bolus versus continuous infusions, you have a higher probability to reach the PK/PD target using continuous infusions. And we observed similar data in one of our studies comparing equal dose of CVVH-DF and CVVH at an effluent rate of 30 milliliters per kilogram per hour. And we could observe highly stable concentrations over time using continuous infusions. And in this study, comparing different modalities, we could also observe that the clearance related to continuous veno-venous hemodiafiltrations was higher than CVVH, but this was not clinically significant. So it may have a difference between modalities, but no impact in terms of clinical input. The second renal replacement dosing rules is that the main determinant of CRRT-related clearance is the physicochemical properties of the drug you use, whether it's hydrophilic or lipophilic, and the effluent rate you apply to your patients. And we can just predict which drug will be affected or significantly affected or not based on the physicochemical properties of your drug first. And what we do know that is dosing adjustment is not necessary if the renal clearance of the antibiotic you use is less than 25% of the total drug clearance. We also do know that the highly protein-bound antibiotics or antimicrobial agents will be less affected, as it's only the free fraction of the drug that can be cleared by the filter. And for example, teicoplanin, cefazolin, or for antifungal agents, echinocandins or amphotericin B will be less and less affected by the TRT-related clearance. And finally, lipophilic drugs that have mainly hepatic metabolisms will be less affected as well. So based on these properties, we can just try to classify high-risk drugs as represented on this graph based on the protein binding and the volume of distribution of the drugs, the antibiotic you use. And we have low protein binding and low volume of distribution drugs here that has higher risk, especially we can see aminoglycosides or even new drugs like ceftolozane and tazobactam. So we know that we have different drugs with different risk of inappropriate dosing. So now let's go back to some basics in PK, how we should adjust the drug dosing for these patients. And first of all, I think the key message is that we need to give our patients a high loading dose, especially in patients with sepsis and illness severity. And I just remind you, but I'm pretty sure all of you know that the loading dose we give to our patients has to fill the volume of distribution of your patient. And sepsis in particular will lead to increased volume of distributions, meaning that we need to give higher loading dose to fill this increased volume of distributions. But this is totally independent from the elimination rate of your drugs. And the sickest your patients, the highest the volume of distribution is, and this will directly impact the loading dose you will give to your patients. As you can see on these equations, the maximal concentrations for your patients will depend on the volume of distribution, and so the loading dose you will give to your patients. And we developed a population PK model years ago when I was in Brisbane, and we identified that for patients on TRT and receiving aminoglycosides, the optimal dosing regimens was high loading dose, high dosing, up to 25 milligram per kilogram. Giving a higher dosing was not necessary, because we will increase toxicity but will not increase efficacy. But what we have to do is to extend the dosing interval to maintain efficacy but to decrease the risk of toxicity. And in this model, the 25 milligram per kilogram every 48 hours were the optimal dosing regimen for these patients on CRRT. So first of all, give high loading dose, including for patients with renal impairments and receiving CRRT. But then we have to adjust the maintenance dose that directly depend on the elimination rate, and so on the residual renal function of your patients, if your patient is not anuric, and the CRRT intensity you apply to these patients. And we have now data from years showing that there's a correlation between drug clearance and CRRT intensity. And so the highest the intensity you apply to your patients, and the higher you will have to give a maintenance dose. And we have data for all different modalities. Here it's an example from meropenem and CVV-HDF. And you can see a quite strong correlations between the effluent flow rate that you apply to your patients and the CRRT-related clearance for mirror, meaning that if you increase the effluent flow rate for your patients because you want to have a higher elimination rate, then you will have also to adjust the meropenem here drug dosing. We also have similar data for CVVH, and here is for cefepime. And we can see that on this graph, doubling the ultrafiltration rate from 1 liter per hour to 2 liter per hour will significantly decrease the probability to achieve optimal concentrations. And for CVVHD, we also have similar data showing that it's the dialysate flow rate that will influence the clearance of the drugs. And here for ceftolozane tazobactam, and it's quite important also to observe what happens for beta-lactam inhibitors. And we can see for this drug, for example, that there's a quite strong correlation between the dialysate flow rate you apply. And so probably in the next future, the effluent flow rate or the CRRT setting you apply to your patients will become part of the dosing recommendations, and hopefully will be part of the drug package insert. And I show you here for this cefiderocol that was released on the market really recently. We already have data showing how to adjust and which dosing regimen we should use based on the different effluent flow rate you will apply to your patients. So that's the main determinant for these patients. And quickly, I will go to the other factors that can affect, but less affect the antimicrobial drug dosing. It's the type of hemofilter that you will use. And we have now quite old data showing that for vancomycin, for example, the clearance of vancomycin may differ at the same dialysate flow rate, depending on the membrane, the filter you use. And some filters like the AN69 will have a high protein absorptions and may lead to increased clearance. So when you do look at the data available in the literature, you will have to see what was the RRT settings applied in terms of effluent rate mainly, but also the type of hemofilter that was used in this population if you want to use the dosing regimen recommended on this literature, based on this literature. Another factor is the hemofilter lifespan, and we have now longer filter life, especially when we use regional anticoagulations. And what we can observe for long durations of filter is sort of accumulation of the drugs. So when the end of the life time of the filter occur, maybe we could experience some overdosing, but I'm not sure it's really relevant on a clinical point of view. More important, the reduction of your patients may lead to increase the dosing. And that was a very interesting study conducted some years ago, showing that for patient that was anuric for meropenem here, 500 milligram per Q8 hourly was enough to reach the target in these populations. But when your patients will have diuresis, and especially up to 5 milliliters per 24 hour, so come from anuric to restore diuresis, maybe this dosing regimen may not be enough, and you will have to increase the dosing, or in this study, go for a prolonged infusion if you do not use continuous or prolonged infusions for beta-lactam in these patients. And finally, you need to remember that continuous is not really continuous, and that we have off renal replacement therapy periods. And if it's a long period, like more than 12 hours, then you will have to decrease the dosing when your patient is off CRT. Otherwise, we may observe some, again, overexposure in our patients. And this suggests that for these patients, we should use therapeutic drug monitoring to better adjust drug dosing in this complex population. And it's what the French recommendation suggests. That's also what this really nice position paper recommend for especially beta-lactams in critically ill patients and for those receiving renal replacement therapy. And when we do perform TDM in this kind of patients, what we observe is that we can have picked up the right dose, but we will for some patients have to increase the dosing based on TDM, but most of the time we'll have to decrease the dosing regimens because we may observe toxicity. And I think the key message is that at the very beginning of the antimicrobial therapy, probably we should not care too much about toxicity. And it's what we can observe in this study for piperacillin tazobactam. When we measure blood concentrations, we can see quite adequate concentrations. But for late TDM, meaning after 48 hours, we can observe that the plasma concentration can raise really, really high. And for these patients, we may observe like confusions or even convulsions or other neurotoxicity characteristics. So I think that the message here is to say that at the very beginning, in the first 48 hours, we should give full dose of antimicrobial to our patients to ensure efficacy. But quickly, we need to adjust the dosing to TDM if it's available at your institution, or to adjust the dosing to renal replacement setting and residual renal functions to avoid toxicity in our patients. And we'll definitely need some tools to help us to be more precise, to determine the right dose for our patients. And there's some software that we can use at a bedside, some freely available software. And we have not a lot of data, but we have some data showing that it may help to achieve optimal concentration for these patients with a high inter-individual variability again. So to conclude, in the future, we'll need to individualize drug dosing based on the characteristic of the patient, its dosing history, of course, the pathogens, but mainly based on renal replacement therapy settings. And we need the help of model-based Bayesian forecasting with TDM to try to determine the optimal dosing strategy for these quite complex patients. And if you don't have TDM available, I do recommend dosing guidance to determine the best dosing regimens, and I encourage you to read this really nice review published recently on optimal dosing in patients in renal replacement therapy and extracorporeal membrane oxygenation. Dr. Abdulaziz for this topic. And I do thank you for your attention.
Thank you, Claire. That's a wonderful presentation.